Hello everyone. So today we will be talking about the myopathies, which is an important topic for USMLE Step 2 CK. And in myopathies, let's just talk about general things what we're going to talk about in this video. So we're going to talk about like different types of myopathies, and then we're going to talk about their features. The important features include the ESR. Remember, ESR is a non-specific sign of inflammation, so anything that is inflamed in the body, ESR will be raised. For example, joints are inflamed, ESR will be raised. If the muscles are inflamed, ESR will be raised. CK is more specific for the muscles. So, for example, a muscle is damaged, CK will be raised. Then we're going to talk about which type of myopathy leads to muscle weakness and which leads to pain or tenderness. Pain or tenderness. So let's first talk about the PMR, which is the polymyalgia rheumatica. So polymyalgia rheumatica, there is inflammation, but you have to know like which part is inflamed. So remember, it's the inflammation of the tendons and the ligaments. So if this is, let's say, a shoulder joint, which it commonly affects. So let's say if it is a shoulder joint, and these two are the bones, and then this is the ligament, and then this is the ligament. These are attaching these two bones together. So these tendons and the ligaments attached to that joint, those are inflamed. The muscle itself is not inflamed. That is an important point to know. So if there is inflammation, so ESR, it will be raised. But like I said, the muscle is not involved, so the CK will be normal. Then let's talk about the weakness. So as the muscle is not involved, there will be no weakness. There will be no weakness. And then the pain and tenderness, because there is inflammation, and we know from the inflammation criteria that one of the criteria for inflammation is that there is pain involved. So pain or tenderness will be there. And one high yield point about the PMR is that it is associated with giant cell arthritis. Another thing is that you don't need a muscle biopsy for confirmatory diagnosis. You can diagnose it by just a response to low dose steroid. So if a myopathy responds to low dose steroids, then that is confirmatory for polymyalgia rheumatica. So then second, let's talk about the hypothyroid myopathy. The hypothyroid I've highlighted just so that you don't confuse it with hyperthyroid myopathy. So here the ESR is actually normal because there is no inflammation going on in hypothyroid. The CK, it is going to be increased because there is muscle damage. Remember, so in hyperthyroidism, the CK will be normal. So that's why you need to know that we are talking about hypothyroid here. And then weakness, there will be weakness, and there will be pain or tenderness. And the reason there is weakness is because the CK is raised. So the CK is raised, which means the muscles are damaged. So that's why there will be weakness. And the pain and tenderness will be there in case of hypothyroid. Then we have the statin myopathy, kind of similar to the hypothyroid. There is no inflammation, so this will be normal. CK will be raised because there is muscle damage. Weakness will be there, or may or may not be there. So this is variable. It can or cannot be present. So that is important. And then pain or tenderness, yes, it will be present. So one of the things to know about the statin is that you need to do TSH before initiating statin. That's one thing you need to know, because if the patient is subclinically hypothyroid, then the myopathy of these two can combine and result in a very severe myopathy. Another thing about the statins is that, let's say a patient develops mild muscle damage or mild myopathy on statin. So what you need to do is switch the patient to a statin that has a lower risk for myopathy. These include pravastatin, pitavastatin, and fluvastatin. So these three has a lower risk, and you can switch them to these statins, or you can reduce the dose if you're putting them on high dose statin. Another thing is to be aware of is that if there is rhabdomyolysis, then you stop statins entirely. There have been case reports where it was successfully given after the patient developed rhabdomyolysis on statin, but usually it should be avoided entirely, even though it has so many benefits. So then we have the steroid myopathy. So in steroid myopathy, there is no inflammation. So this will be normal. Also, the muscle is kind of atrophied. There is decreased synthesis of the protein, but the muscle is actually not damaged. It's just atrophic. So this will be typically normal. Then comes to the weakness. Weakness will be present because muscles are atrophic, and the pain and tenderness, no, because there's no inflammation. Nothing is kind of going on here. So then we have the inflammatory. So the inflammatory, we know that these include the dermatomyositis and polymyositis. And remember, the confirmatory for these two is you need to do biopsy, and also look for malignancy in these two, because these two can be a result of paraneoplastic syndrome from a malignancy. So inflammatory myopathy. So this is kind of easy because there is inflammatory. They're telling you there is inflammation, so this will be raised. CK, there is muscle damage, so it will be raised. And then we are coming down to the weakness, because there is muscle damage. It will be present, but pain and tenderness, even though it is inflamed, but it's usually it's not present, so it's uncommon. So these were the high yield myopathies, and I hope this video is helpful.